Good afternoon. Thanks very much for joining us today. My name is Lizzie Button. I'm a Practice Liaison Officer with the Oxford-RCGP RSC. And today I'm going to be talking to you about our COVID-19 vaccine effectiveness surveillance, which is using serology to measure vaccine effectiveness in addition to our usual virology swab sampling. In today's session, I'm going to be covering some of the theory and practicalities, as well as touching briefly on how the data is used, as well as some further information and FAQs. And if there is one take-home message, it is this. Please continue with serology and virology surveillance. That's both sampling and swabbing, especially in older age groups, both pre- and post-COVID-19 vaccine. This collection is largely an extension of our already ongoing general serology and virology surveillance. For those of you who are already familiar with this, it will be quite an easy transition. For those of you who are not, I urge you to please visit our now updated surveillance page, where there is some further guidance for HCAs and phlebotomists. But just to cover some of the basics, serology is important for measuring exposure to COVID-19 and assessing background immunity in the population. Virology surveillance is important for monitoring the spread of COVID-19 and vaccine effectiveness. The same eligibility criteria apply for serology. That involves taking an additional opportunistic blood sample from anyone that's attending a routine blood appointment. And for virology, it's swabbing anyone with acute symptoms of influenza-like illness or a lower respiratory tract infection within 10 days of onset. This can be done using either our in-practice kits or through a voucher code system that practices can give to patients to order self-swab kits to their home using the Take a Test website. But I'll cover a little bit more of that in a moment. Crucially, it also involves coding into the patient's clinical medical record that a sample for serology has been taken or that a swab has been taken or offered for virology. The main difference in this collection is that we are aiming for 3 matched samples from the same patient, both pre- and post-COVID-19 vaccine dose. And this is really to help us assess vaccine effectiveness per dose. What this requires from the practices is to ask patients if they are willing to give follow-up bloods, or at least if they consent to be contacted about this in the future. So in terms of targets across the network, I'm going to start in the middle here with the serology sampling. As you can see, we're looking for 3 samples at 3 different time points. The first sample, we're aiming for around 5,000 samples, is before the patient has received their first COVID-19 vaccine dose. Any samples that may have been collected since around the 1st of November can still be included in this collection, but if the patient is willing to take another sample, that is even better. The previous one will not go to waste. And really we're looking to achieve that target by around the 1st of March, which obviously is just around the corner. We're then looking for a second serology sample. Again, across the network, we're looking at 3,000 of those, which are matched to the first sample. And ideally, we want that to be taken just before the second dose, around 12 weeks after the first dose. Now, obviously, these are approximations. Patients are being asked to come for their second COVID vaccine dose within 12 weeks. But really, the more practices we have participating in this program, in this collection, the more likely we are to achieve those targets. So really, if in doubt, please sample. As I said, nothing will go to waste. We're then looking for a third serology sample after the patient has received their second vaccine dose, and that's roughly around 12 weeks after their second dose. Meanwhile, we're really looking for virology sampling to continue across the network. Again, we're looking at around 1,000 per week. I know that virology swabbing is a bit of a challenge right now because patients are not really, they're not coming to the practice, they're not really being consulted necessarily and going straight to pillar 2 testing. But as I mentioned, we are encouraging practices to use those voucher codes to try and boost these numbers. So what does this mean per practice? We've suggested around if practices could aim for around 5 to 20 samples per practice per week, that would really help us to achieve our targets. Since the beginning of January, we've had a couple of star practices that have managed to send through just over 100 samples. Now, obviously, not every practice is going to be able to do this, but the bottom line really is that if you are already sampling, and maybe if your numbers are a bit low, to please try and do a bit more. Or if you're completely new and haven't done this before, then please do get involved. It would really help us achieve our targets. Within this collection, we're looking at particular priority groups. These groups are largely aligned to the JCVI priority groups. That's the Joint Committee on Vaccination and Immunisation. But essentially it is to collect serology samples from older age groups, those who are 65 years of age and above, care home residents, those who are clinically extremely vulnerable, or part of the BAME population. Up until now, we've been really focused on serology samples from pre-COVID vaccination, but we are now also looking for serology samples from anyone who has received a vaccine dose, especially in the older age groups. Do please check out the Covid-19 vaccine effectiveness page for a more thorough breakdown of those groups. And it goes without saying, obviously, as the vaccination program continues, that our target age groups will get younger. But for now, the focus really is on those older age groups. Another priority is to continue with virology swabbing from anyone who is symptomatic, that is acute symptoms within 10 days of onset. For those of you who are not familiar, we have traditionally, practices have used in-practice testing kits to collect virology swabs. Since September, we have introduced a parallel system whereby practices can receive weekly voucher codes. They then pass these voucher codes on to patients who can order self-swab kits to be delivered to their homes via the Take a Test UK website. You will need to be set up through us to receive those voucher codes. So if you aren't already receiving those codes, do please get in touch. We really encourage practices to take up the voucher code system to help get our virology swabbing numbers up. I have spoken to a couple of you around research swabs and pillar 2 testing, and really the message is that a second swab is not a waste, because firstly it gets tested for other respiratory viruses, and also because it provides a richer source of data as we're able to link test results to a patient's clinical medical record, which allows for some more granular analysis, for example, on the effect of comorbidities. Some of you have also been in touch that if a patient tests positive again, from what point do they need to isolate? You can reassure them that they only need to isolate from the date of their first test. And if you visit our surveillance web page, we've added some additional materials to support in this. In terms of monitoring of how we track, how to track patients across different time points, we do receive some pseudonymized results for serology and virology, and we'll be able to provide some monitoring support to practices that are participating in this VE collection. But that's really dependent on the coding, which is why it's so important. I have spoken to a couple of you about a lab form. This is still in development, and when that is released, it will allow practices to indicate which sample they have collected. And we're also updating the patient information sheet just to include that little caveat about being contacted for follow-up samples. But in the meantime, please do continue to use the current general serology surveillance lab form that's available on the surveillance page. It would also be really helpful if practices could keep track of who has consented to be followed up with internally, and to report those numbers back to the practice inquiries team. But if you do that, please do not include any personal identifiers. So no NHS numbers, no names, just the number of patients who have consented to be followed up with. In terms of reimbursements, practices will be paid in the same way as for general surveillance. For serology, that is £5.50 for each matched sample, and for virology, that is £7.50 for each matched sample. I'm aware that there's been a bit of a delay recently in processing payments. We're really sorry about this, and we are working as hard as possible to get through this as soon as possible. Now, I've put together a couple of suggested approaches. These are mostly our own suggestions, but some of it is also from practice feedback. For serology, it really is about collecting those opportunistic blood samples during routine blood visits to the practice, but also including during any home visits. We have previously sent out some communication about trying to collect blood samples whilst patients wait for their vaccine dose. This has been feasible in some clinics, but not in others, and obviously should only be done if it's safe to do so following PHE guidelines. As I've mentioned, for the virology, we're really trying to encourage practices to administer the voucher codes to patients so that they can order those self-swab kits to their homes. Some practices have been communicating to patients ahead of time via text messages. And recently we have been working on some promotion material that is a little bit more patient orientated to try and boost engagement that way. And if you are interested in either putting up a flyer in your practice or maybe adding a web banner to your website, please do get in touch. Just a little reminder on how the data is used. We've had some feedback from practices that this might be really useful for patients as well. Now, obviously, this data gets used internally. The Oxford-RCGP RSC publishes a weekly communicable and respiratory disease report. It also gets used in national flu and COVID-19 surveillance reports that are published by Public Health England, as well as various publications. And I've plucked a couple of examples here just to really illustrate how that granular kind of data allows us to do some really important analysis. For example, on the impact of age, sex, ethnicity, household size, and long-term conditions on excess mortality, or the effect that this is having on primary care organisation, or on risk disparities. So I appreciate you're all really busy, but if you are interested and do have a little bit of time, I would encourage you to take a look at our website and to have a read through some of these publications. So that just about sums up the session for today. I've included a couple of links, mainly to the Oxford-RCGP RSC ORCID website. There is the link there to the COVID-19 vaccine effectiveness page for further details on this collection. I do urge you to take a look at the surveillance page, especially for the forms. The forms should not be confused with the convalescent serology collection. Please do make sure that you're using the right form. We have a new webinar and podcast page as well. Do keep an eye on that for any upcoming webinars, and the links to this webinar and others will be posted there. For those of you who are looking to order virology or serology kits, this can be done through our material requests portal. We are also planning to host a couple of additional webinars to support this work, including potentially a kind of practice roundtable where practices could sort of offer suggestions of things that have worked well or any barriers they're facing. So if anyone would like to volunteer to take part, do please get in touch with me. You can do that via the practice inquiries email or on my email elizabeth.button@phc.ox.ac.uk. And that just leaves me to say thank you for joining.